Well, hello, everyone. Good afternoon. I'm going to give everybody just another second or two to kind of get in from the waiting room. Hi, guys. So I'm Christy Capra. I am your Randall Children's PediaNet coordinator. Welcome to Randall Children's Grand Rounds today. So we have both virtual and in-person options. So if you're here on campus, come on down, get some pizza. There's plenty out there. But we just want to thank you all for being here. So before we get started, just a quick reminder about claiming your CME credit. There's a QR code on the slide here. So after today's presentation, you can scan that and claim your CE credit. Remember that you only have 30 days to claim that. So make sure you get in and claim that. And of course, if you have any questions about that, let us know. We can help you with that. Following the lecture, we'll open the floor for questions. So if you're here in the audience, I'll bring you a microphone so the people at home can hear you. If you're at home, go ahead and put your questions in the chat and we'll be sure to get to those as well. And now it's my pleasure to introduce Dr. Wendy Hassan, the medical director for our pediatric intensive care unit here at Randall Children's Hospital, who will be given our formal introductions today. Thank you so much, Dr. Hassan.
All right. It really is a great privilege to introduce Dr. James Ellis today. I have to say, the farther I get into my ICU career, the shorter the list of diagnoses that really make me sweat through my scrubs. I'm happy to share that list after Grand Rounds if anybody's curious, but I do want to say probably one of those top 3 diagnoses for me are the very large body surface area burns. And I actually had the privilege of meeting Dr. Ellis last year after he started while I was sweating profusely through my scrubs while I'm a patient with the largest body surface area burn of my career so far. And I have to say it was a very harrowing, but also immensely successful experience for all involved. And it was my first time working with Dr. Ellis. And I think 3 things were very immediately clear to me. Number 1, that Dr. Ellis is a man of great clinical acumen and ability. Number 2, that Dr. Ellis, when clinically appropriate in the moment, has a pretty darn good sense of humor. And number 3, that Oregon Legacy and the Oregon Burn Center are incredibly fortunate to add Dr. Ellis to their already immensely talented roster of burn surgeons. Dr. Ellis is originally from Southeast Tennessee. He completed his medical degree at Kentucky College of Osteopathic Medicine, followed by general surgery residency at Mercy St. Vincent's Hospital in Toledo, Ohio. He then traveled to Galveston, Texas to complete his training in burns and surgical critical care at the University of Texas, with a special focus on pediatric care at Shriners Hospital. Thank you, Dr. Ellis. We're so lucky to have you.
All right. Well, thank you so much, Dr. Hassan, for that incredibly nice and heartfelt introduction. That was, to everyone that's here and to everyone online, thank you very much. Thanks for Randall's for giving me this opportunity to talk. Just to talk about my background very briefly, I started out as a nurse. I ended up somehow heading down towards the medical route, onto the provider side, ended up, in medicine, thinking I was going to be an infectious disease doctor, and then just really fell in love with surgery after a great time down in Southeast Kentucky. And then fell in love with burns because of the critical care aspect of it. And I really just enjoyed these extremely sick patients, very vulnerable population. In particular, pediatric burn, which is why I, had the honor to go down to Galveston, Texas, to work with Shriners down there, and that brought me up here to where we are now, and with some fantastic partners at a fantastic institution. So I'm going to go ahead and get started on the lecture today. Okay. Assuming I can figure out the button system. And then, okay, there we go. All right. Okay, I have nothing to disclose. And then basic objectives for today. We're just going to sort of do the 30,000-foot look at the pediatric burn population and the pediatric burn patient, that burn survivor from initial injury on through to their hospital course. Things we're going to touch on, trends in pediatric burns, the most common ones, fluid resuscitations, and of course, the big things, airway management, inhalation injuries, and then some nursing considerations, because again, this is a relatively small population, but a very sick population. Okay. All right, so our pediatric burn data here at Legacy is about 20% of our population is going to be pediatrics. Of those, only about 20% or less end up requiring ICU level management and care. And the most common cause of burns in our kiddos is consistent with nationwide trends, which are scalds and contact burns. And this is just a bar graph of our population from 2023, so a little bit dated, but these trends do hold in the years following. And you can see that the most common cause of burns in particular is going to be in the 0 to 11 months and the 12 to 23 months out to 3 years. And you can see a significant amount of this, over 50% of our patients are going to be between contact and scald. And that, interestingly enough, the older a patient gets, the more that trend starts to come back for the same reasons, not being able to hold something very easily, not having the dexterity, spilling things on yourself. So when we talk about pediatrics, you hear this every single time you work with pediatrics, is that they are not small adults, and that this holds true in the burn world as well. In particular, the younger a child is, the higher their relative body surface area to weight ratio. So I always say that this is something like a balloon, right? The bigger the balloon is, the more volume of air inside the balloon compared to the skin of the balloon or the skin of the ball. And in this case, the amount of energy lost in the form of heat is one of the things we think about, or moisture, is significantly higher in these kiddos because they do have such a relatively large amount of skin for their size. Additionally, children under 2 years of age tend to have a thinner dermal layer than adults or older kids. So they do tend to get full thickness burns with either less duration of contact or with a similar temperature that would give an adult a partial thickness burn. Luckily, they do have a significantly higher regenerative capacity, so sometimes even these thicker burns do turn out okay, just because they're kids, and kids are very sturdy, very durable. And then, of course, temperature regulation I briefly touched on. These kids get cold very quickly, and that is just due to that large body surface area to their weight. Plus, they have a generalized a lower body fat percentage on average, depending on the size of the kiddo, and that can play into energy stores, play into temperature loss as well. So what are some other ways that kids are different than adults? Things that really play into our management as first responders, burn providers, the ICU team. The airway is a big one, right? Airway is very, very important. It is one of the most important things for us because very quickly they can swell, they can obstruct, they can have neck swelling, poor mobility, the skin on the face can be damaged, making it hard to secure tubes. So airway management, very critical. The airway in kids tends to be more anterior than adults, and the most narrow portion is actually the cricoid cartilage, and that really plays more of a role when it comes to things like choking. But compare that to an adult, where your narrowest point is your glottis. They're going to have small minute ventilations. They're going to have more rapid respiratory rate requirements. And then, of course, the circulation, the resuscitation imbalances in kiddos can happen very quickly. And part of that is due to the relative higher body water ratio when compared to an adult. Plus, the glucose concentrations tend to drop very rapidly, especially in the early stages of a burn injury or resuscitation. And that is due to the lower relative glycogen stores. Although this does start to correct out as they get older, when you start looking at kids, 6, 7, 8 years old Okay, so this is just a one-shot slide to give you a brief overview of the most important things we look at when we're thinking about burn tissue physiology. So a burn injury, different from other types of trauma in that it triggers a massive inflammatory cascade similar to lung-type injuries or traumatic brain injuries. It causes severe vasodilation by the overproduction of vasoactive inflammatory mediators. These are things like complement pathways, your cytokines, your IL-6s, your DAMPs, which are damage-associated molecular patterns. These are essentially signals to your body that there's been a trauma or an injury somewhere. And the ratio of the size of the injury to the response is essentially nonlinear in these burn injury patients, meaning a relative smaller burn can have a larger inflammatory response. Now, one of the things we talk about and you'll see is, well, what size really triggers this sort of systemic inflammatory? We classically say 15% and up, but as you'll see, and every patient is a little bit different, this is to catch most people. So a burn 15% or more TBSA will catch most folks that are going to have an inflammatory, response, this burn shock. There are going to be people 10% that have it. There are going to be people 25% that don't have it, but this is a good general cutoff point. Although some large database review in the more recent years has shown us that where you're burned also matters, and that an arm burn totaling 5% will not elicit the same amount of inflammatory response as, say, a face, neck, head, or genital burn of the same size. So things to consider, especially when you look at your resuscitation and the morbidity associated with where these burns are. Okay, so fluid resuscitation. This is the cornerstone of our burn care at the onset of injury. We know that the burn injury happens and you very rapidly go through a couple of phases. You have a distributive shock component. Your blood vessels dilate. You have a tachycardia. You have hyperkinesis of the heart muscles. You will have this increased ejection fraction. You will have a relative loss of volume by having this dilation. But on top of that, you also have a true volume loss in the form of evaporative losses and transudative losses from the burn wounds. These losses are sort of more pronounced in kids because of that higher body surface area. So what you may have is volume loss, as this example shows, a 20% burn in a child that weighs 10 kilograms. It's going to cause about 475 milliliters, so 60% almost of their circulating volume lost in burn, evaporative losses and transudative losses in about a 24-hour period. So you're looking at this is over 24 hours. Compare that to a 1.1 liter loss in an adult, which is a 20% loss roughly of their circulating volume, which is just enough to make your heart rate go up a little bit, maybe. And then you look at what's our resuscitation goals. For all comers, we look at urine output. That's a really good driver of, are we doing a good job? Are we maintaining perfusion? Are we getting fluid into the kiddo? Are they able to get it out? And for kids, we look at about a 1 milliliter per kilogram per hour to say, this is a good urine output, this is an acceptable resuscitation. All right, and then over on the left, you can see just a modified Lund-Browder chart to give you an idea of what the surface area of the kiddo is. And you'll see down there on the bottom, it's adjusted by age. So as you get older, the head takes up a smaller portion of your body surface area. And then, the arms and legs in particular start to take up more. Torso ratio stays very similar, it doesn't really change. So our resuscitation goals, we talked about urine outputs. So the end goal here, we're not trying to play catch up. We're not trying to fully replace every ounce of fluid this patient has lost. we are trying to maintain perfusion. We are trying to keep up with ongoing losses. We are trying to correct out and support the body to allow for homeostasis. We want the body to start correcting itself. The way we do this is with volume therapy. Now, volume therapy is an ongoing research topic. It is a hot topic every single year, and every few years it always comes up. Are we doing this to the best of our ability, or are we working on data and paradigms that were set in the 1970s? And we're still trying to get there, but the mainstay fluids right now, crystalloids, although colloid, in particular fresh frozen plasma, or FFP, is starting to move to the forefront of our discussions, which is interesting because you look back in time and some of the original burn resuscitation protocols were developed with plasma in mind as your secondary fluid to be administered along things like lactated ringers. And then, of course, other colloids such as albumin can be used. And the end goal here, minimize your complications from organ failure, right, from under resuscitation or from over resuscitation, with both of these having potentially devastating outcomes. All right, so you get that call, they're on scene, they're intubated, they're telling you massive burns. What do we do? With kids in particular, you're less than 30 kilograms, your younger kiddos, under 13, we start a maintenance IV fluid because we know that there is a relative decrease in total glycogen stores available. We know that the brain of a toddler uses almost twice as much total glucose, per weight than an adult brain, because as adults, we don't think. We are on cruise control. We're not learning new things. But kiddos, they're growing. They're using this energy. There's been data that shows us that kids don't stop growing while they are recovering from injuries, while they are having, these catastrophic events. Their body is trying to do two things: get bigger, heal. And sometimes those collide. So our purpose here is to supply what they need. Don't oversupply, but make sure that you do not suffer the consequences of things like hypoglycemia, severe hypoglycemia, seizures, brain swelling. These are all concerns that we have. So we do a maintenance rate on these kiddos of a dextrose-containing fluid, which is D5LR classically. The rates for these kids, we use the old 4-2-1 rule, which is sort of listed here. And it helps to account for the fact that we are not typically able to feed these kiddos early on. And the younger you are, the bigger your burn, the more likely you are to have gastroparesis, ileus, difficulty with enteral absorption. So, especially in the beginning, we give them dextrose any way we can, and that's typically through your IV fluids. You get the kiddo into your hospital, you've got a good resuscitation going, and you're saying, okay, we're starting to look better, we're plateaued. How do we know when to stop? Because classically, as providers, physicians, we are very good about giving people what they need and very bad about de-escalating when they've had enough. And, historically, and you're going to see a picture in this next slide that's pretty graphic. It's something that can have devastating consequences. So we're looking for hemodynamic stability, right? Are they off pressors? Are they maintaining themselves without, the help of either vasoactive agents, without inotropic agents for some of your smaller kids? Do they have the adequate urine output that we discussed earlier? Reversal of acidosis, not as strongly supported, but still a good marker and trend that we, can look at. So are we moving in the right direction? And then this bottom bullet is really generally met at the 24th hour. And I will say, if you do this enough and you see enough of these big burns, you'll realize that At that 24th hour, they do tend to look pretty good. And then at hour 32, 36, they're not as good anymore. And that's just, that's when you tend to see well, we've done enough and then we did too much. So next slide, again, some graphic imaging here. So when we do too much, what happens? Over resuscitation carries a higher mortality rate than under resuscitation in our pediatric burn patients. This is a photo of a child, not while I was there. This is before my time, but this is at the hospital I trained at, down in Galveston, Texas. And you can see that there is an open abdomen. There is a bowel bag trying to keep things moist. There are escharotomies, those incisions through that thick burn down into the level of the fat to allow for expansion of the tissues. You can see this kiddo, he's intubated through the nose, okay? And they're in the operating room getting ready to do presumably a fascial excision, which is you take all of that leathery eschar off down to the level of fat. You put on a temporary skin and you try to stabilize them and get them out of that acute inflammatory state. Typically, this happens when you get that patient that comes in and this is catastrophic. You see it, it's scary, they're not making urine. The blood pressure is tanking. What do? You bolus, you get fluids, 10 per kilo, 20 per kilo. You're given more rate, you're having trouble oxygenating, ventilating. It's a panic mode and it is distressing for everyone involved. However, kiddos are, because of their total body water content, because of their relative, paucity of fat stores on the inside the abdomen, they tend to create massive ascites very quickly. And that massive ascites causes abdominal compartment syndrome. In adults or older kids, it tends to be more bowel wall edema rather than ascites, and that just has to do with the thicker mesenteric root, the higher lymphatics, flow rates, and they're a little bit easier for them to maintain the fluid inside the vessels or the tissues. And then as those pressures go up, you start to lose perfusion from the kidneys, not from arterial input, but from venous return. You get congestion, any encapsulated organ, kidneys, liver, the brain, anything that is contained within a space will start to swell. And then you end up in a position where you have to open the abdomen because you cannot get venous return back to the heart, and the patient is collapsing in front of you. And unfortunately, this carries near 100% mortality. The open abdomen plus renal failure is near universally fatal in these big burn injuries. The other thing, let's say the abdomen was closed, we also end up worrying about pulmonary edema. Even with good fluid management, that inflammatory response can trigger such a significant pulmonary inflammatory reaction that they end up in severe ARDS, severe hyalinization, rapid hyalinization, as little as a week to 2 weeks. This has been demonstrated in animal models, in particular in sheep models, that the lungs will very rapidly lose compliance, will thicken, will have difficulty with fluid and gas transfer, and you end up potentially on ECMO, which, similar to an open abdomen, carries a very high mortality rate, although it is getting better as we get better and our technology improves. ECMO is closer to about a 50 to 60% mortality rate, although again, those numbers are improving at big centers. So what's the opposite end of this, right? When the pendulum goes the other way? So over resuscitation kills more people. Under resuscitation, more comorbidities. Why? Well, it makes sense. If you live long enough, meaning you make it through your burn, you live to see the renal failure. You live to see the liver damage, the in rare cases, the almost cerebral palsy type symptoms where you get kiddos that have long-lasting neurologic deficits because of brain hypoperfusion and carbon monoxide exposure, particularly in structured fibers. In these cases, we worry about that shock state. We worry about that low flow. The kidneys are the first thing to be damaged and tend to be the last thing to recover. The kiddo or a patient in general that ends up on CRRT or dialysis automatically has joined the 80% of patients that do not survive a massive burn injury. So that instantly puts you into that category of patients that are less likely to survive. Add that to an inhalation injury, and you have jumped up to about a 92% chance that you don't make it through this injury. And that, even in these younger kiddos, that's the biggest population of non-survivors, is the combination acute kidney injury and inhalation injury that results in dialysis of some sort, apart from, of course, the open abdomen. And then the other thing we worry about on both sides of this is burn progression. You come in, we say, this burn, I'm looking at this and I see areas where it's a little bit pink, right? The skin, the top layer, it's desquamated. The pink is potentially a little bit of early hemorrhagic response from thrombosis of the vessels, but it may be that it's just a partial thickness burn. Low flow to that dermis has the potential of increasing the area of what we call the zone of coagulate, or the zone of necrosis, and then the zone of stasis, which is that, when we're talking about it like a dartboard or a target, we want that area of threatened tissue to shrink. And we want that area of hyperemic or well-vascularized tissue to grow towards the center so that we have less tissue needing excised, less grafted. Okay, and so this is something where, a lot of people will see some degree of burn at some point. It's the very massive ones that tend not to be seen very often, but because these do pop up from time to time, we've got some considerations and assessments for the bedside. One of the big ones is in these early big burn resuscitations, the abnormal vitals are the new normal vitals. You expect patients to be tachycardic. You expect them to be oftentimes low normal to hypotensive as far as blood pressure. You may or may not have good wall motion of the chest, a good belly rise of the abdomen, depending on the thickness of the burn, the tightness of the tissues, the amount of edema. Things like endotracheal tube positioning. Oftentimes we say, it's X at the lip. Well, if your lips are leathery eschar, unable to expand, if they're swollen, etc., we do not, that's a shifting mark. So we measure from the teeth. Oftentimes we'll secure tubes, at least where I was trained, through a nasal septal tie or through a suture around the tooth or into the maxillary bone, because we need that stability. Urine output. They have Foley catheters. Foley catheter must be checked for patency, right? As these folks go through their burn resuscitation, it is not uncommon for them to have some, acute tubular necrosis, kidney damage, and then for those casts to start flushing through, and then they end up with a lot of sediment in the urine. Sometimes this can clog the Foley catheter, especially in your very young kids with those smaller French catheters. Something you very much do not want is to have a clogged catheter, a distended bladder, reflux into the ureters, and then obstructive neuropathy, because you have the absence of outflow. The compartment syndromes, these are always a consideration in your circumferential burns. This is something where we're always, look at these, check them, feel the extremity for tightness. But unless you see this a lot or have a lot of experience in it, it may seem fine, or maybe we don't know. So oftentimes what, you'll hear or can think of is, well, they still have Doppler pulses. But I always like to remind people, when you lose pulses, when you lose Doppler signal in the extremity, it is too late. The damage is done, because the last thing to go is that little bit of arterial inflow. And those nerves, that myelin sheath, those are the muscles, those are some of the first things injured. You need to open those compartments up. You've got to get that outflow in particular, continue the inflow, and then hope that the damage is not permanent, although in some cases it certainly can be. And then labs. These patients get a lot of labs, and there's a lot of red on your screen. And you're looking at these numbers saying, well, what is the most important wrong numbers of this list? And, we've tried over the years to put this into an algorithm. In modern systems, they're looking at AI to help do some of it for us. But the truth is, there's no one marker for how your patient is doing, and you really have to use that gestalt of the bedside, the lab results, and then what your patient is, doing as far as the numbers they're putting up on the monitor and your exam. Okay, so you've made it through getting them into the hospital, you're in your resuscitation. What are your complications, right? They're here, the burn's done, the injury has finished, or at least we hope. The primary cause of death in the burn patients, so this is all comers who make it through the initial shock resuscitation phase in the early state. So the first week or so is multi-organ dysfunction. You have enough of a hit, either from over resuscitation or under resuscitation, that you end up with multiple organ systems failing, and then an inability to support the patient, and essentially spiraling decline. Now, modern days, we are getting better with support, right? We have ECMO, we have more advanced vent settings, which you can, some of those are a little plus minus, but they do trend towards being helpful, especially in inhalation. But you see this massive inflammatory shock, you see this massive burn shock, burn cardiomyopathy, the heart just can't keep up, and that tends to be what causes your patients to expire in the early stages. Once you make it past about 2 weeks, infection, in particular pneumonia, is by far the biggest killer of our burn survivors. This is compounded really by the fact that they've got multiple open wounds, potentially prolonged intubation, and as we know, tracheostomy tube does not make the risk of pneumonia go away. It decreases a lot of things: ICU length of stay, ventilator days, sedation. Does not keep your patients from getting or succumbing to pneumonia. Long-term lines. There are kiddos that have had a single groin line over wire exchange multiple times for months, and you do the best you can, but this is just a source for infection. They will get line clots. Those clots will seed with bacteria, and you just have to hope that their innate immune system is strong enough and that you're supporting them well enough, because you're out of access points. Everything else is burned or inaccessible or thrombosed from previous lines. Urinary catheters in the early stage, we've gotten better at getting away from them faster. And then, of course, the global immunosuppression that comes from these large burn injuries makes them susceptible, in particular, to cutaneous organisms that would normally not pose much of a threat. Things that come to mind are your Pseudomonas, your Acinetobacters, your Klebsiella, Stenotrophomonas. These are all bugs you might hear in passing that may affect some patients, but affect your immunocompromised and your large trauma patients to a disproportionate degree. So in the ICU, at the bedside, looking at your patients, we have criteria for sepsis. we have criteria for that service response, which, in our patients, these again are oftentimes normal numbers, especially in the early stages. If you pull out the textbook and you look at something like the total burn care text, it makes it pretty clear. It says here's some guidelines and recommendations for what we think is signs of sepsis in a burn patient, but this is not hard and fast. You really have to look at this and say, okay, a temp of 39 degrees or higher in the first 48 hours, once they start to rebound, not uncommon. 10 to 12 hours after a major cutaneous surgery, especially on the head and neck, not uncommon, not typically infectious. But, the progressive tachycardia coupled with that high temp, potentially, thrombocytopenia is a big one. You start seeing thrombocytopenia, especially in these kiddos, that is almost universally sepsis, because they, if anything, will try to go the opposite direction. They tend to become, have thrombocytosis, get very high platelet levels because of the inflammatory response. And then hyperglycemia, especially, in your younger kids that don't have as much of a predisposed risk factor. They're not typically diabetic. And then I touched on this earlier. Kids are very susceptible to gastroparesis and ileus, or gastric ileus, I should say, due to infection. And one of the first things you can see in these kiddos is big gastric bubble on your KUB, vomiting with tube feeds, having, vagal events, bradycardia, apneic events. These are all potentially driven by that gastric distension, and is something that needs to be assessed as far as infection. So we talked a little bit about these more common cutaneous bacteria, right? These organisms on the skin that tend to afflict some of our patients. And everyone that I mentioned, for those budding microbiologists at home, we're all gram-negative bacteria. The Acinetobacter, your Klebsiella, your Pseudomonas. But what about the gram-positives? Well, we say staph is still the most common global cause of a burn wound infection. It's not typically the biggest killer because it's it attacks fast and hard, but the ones that form a biofilm and really infiltrate the skin and live there tend to be the ones that get you long term. However, staph and strep are the biggest killers, or in this case, drivers of ICU admissions and care in young kids with minor burns. These are the kids that come in with a scald on the arm and they look fine and they're happy and they're eating and we think nothing of it. And the next day they're still doing okay, but maybe they're not eating as much. They're not playing as much. The arm's a little more swollen. The redness is slightly increased. Okay, well, it hurts. They've gone through a lot. They're getting pain medicine. The next day they are tachycardic, tachypnic initially, and then the respiratory rate will drop. They stop peeing. These kids get septic, and this is typically gram-positive driven, staph or strep, root-based strep in particular, toxic shock. And this can be a rapid killer of kiddos. It can happen to adults too, but kids, highest likelihood, and in these small burns that seem very innocuous. You're not looking at them thinking that's a major burn we should pay attention to. So always something to bear in mind. And that can be any wound, honestly. It can be a paper cut, it can be a splinter, it can be an abrasion. If the kid's not acting right, check those wounds. Make sure we're not missing something easy. Going back to the ICU management of these kiddos. So we've sort of gone through the fluid resuscitation, making sure the wounds are clean, getting those wounds taken care of from an operative standpoint, get the dead stuff off of there, get them in some skin substitute and eventually their own skin. But in this whole process, oftentimes they're intubated, sometimes repeatedly, sometimes tracheostomy tube, but This is another one where we do a good job of intubating the people that need it. We do not do as good a job of not intubating people that don't need it. And again, this circles back to you're in your units, you're in the ED, you're in the field, they're covered in soot, they're swollen, they're screaming, it's everything scary and happening. And you say, if I don't secure this airway now, what about in 30 minutes, an hour, 2 hours, when they no longer have an airway that can be accessed? So we do tend to intubate more than we should. Those hard intubation criteria, respiratory distress, right? So what is that? It varies, but we typically are, saying, are you tachypnic for your age? Are you unable to maintain saturations greater than, for the young kids, 92%? Is this a large TBSA, body surface area burn? And it can be, well, from the waist down, I am badly burned. The amount of sedation and pain medicines that you may need for a successful cleanup, wound care, etc., may necessitate intubation. We try not to, certainly, and there's a lot of adjuncts that we have, but sometimes this is necessary. Upper airway edema, I would say the biggest call, as far as hey, we've intubated this patient, is lip swelling, nose swelling, soot in the nares, carbonaceous sputum in the back of the throat, hoarse voice, raspy, wheezing, all of these things, scary appearing, but it's really hard in the heat of the moment to say one of these is going to decompensate and one of these is not. So truthfully, the safe thing is often they intubate, they come to us, we make that decision, we do bronchoscopy, we look at the lungs, we try to get that tube out as quick as possible. And then, of course, fluid resuscitation. We did touch on this earlier, but that massive amount of volume for some of these bigger burns causes swelling everywhere. And that pulmonary edema can make it extremely difficult for you to keep up, for you to auto-PEEP yourself, to help mitigate some of that transudate. And sometimes you end up just needing intubation until we can get that fluid back off of you, get those lungs healthy again. And then on the other side of it, the tube's in. Now, what are our management strategies? With an adult, you've got an 8.0 garden hose in them. That's not going to kink very easily. You're going to move great volumes. It's pretty easy to maintain. You get a young kiddo, 2 years old, 3, 4 years old, even younger than that. These tubes kink all the time. You have to stack up rolls of pads and Kerlix and gauze. You have to tape them to anything you can, because any little bend in this tube, you've just increased that resistance that their machine, the vent's trying to overcome to get volume into them. You have decreased the lumen size. You have increased the likelihood that the mucus will plug, that there is going to be some obstruction. It's harder to sedate. I've never been awake and intubated, but I will tell you, I've seen a lot of people who are. And having that tube out of your mouth, being unable to close your mouth, being unable to comfortably swallow is miserable. And you can watch these folks, chew through all the sedation medication just to try and keep them from fighting against that breathing tube. And that's one of the things I liked, personal bias, of where I did my pediatric training was we used nasal tubes for all of our patients in which it was feasible. And the comfort level of the patients was much, much higher. And we were oftentimes using oral medications via the Dobhoff tube and push dose medications with no sedation drips, because the comfort is such that they could sit there and watch TV or play or interact without having something pushing on the soft palate, triggering gagging, without having something moving back and forth, being able to close their mouth, move their tongue around, swallow, manage secretions. Again, personal bias, but I found that, this is something that if you can keep that tube out, it's always better. If you can make it comfortable while it's in, then, that's your second best. And then when we look at these patients in particular, they got intubated in the field. One, why, right? Respiratory distress, sedation, swelling, large amount of volume. When we look at inhalation injury, that's when, you talk to me about, oh, well, we tubed this person because they were in a structure. They were trapped in a building, lots of smoke. Then I'm thinking, okay, inhalation, carbon monoxide poisoning potentially, which is a very early thing. We're able to clear it out of your system relatively quickly at 100% FiO2, but that initial carbon monoxide poisoning can cause ischemia and structural changes within the brain, can cause brain swelling, can cause seizures, can cause death. Hypoxia, of course, we want to avoid that at all costs. And then the thermal injury, relatively uncommon. I will tell you that unless it was a steam event to the face, it is very uncommon to see true thermal injury below the level of the vocal cords or extending down into the bronchi. You will see caustic damage from soot, from the acid compounds that are released from certain burning materials. You will see this damage from particulate and chemical. Unusual to see true thermal damage because the body does a fantastic job of cooling down the air that we breathe, even if it is very hot air. Once you get past that first 24 hours, then you look at the second 24 to 72 is when we start to see this pulmonary edema, the atelectatic changes, the collapse of the alveoli, this bronchitis picture, and this is sort of that blooming stage, similar to what you might see in a pulmonary contusion. And then third day on, you tend to get your pneumonias. So, very severe inhalation injury. They'll end up on VDR or APRV, some type of advanced ventilation. They may end up on ECMO. They may end up proning them. Lots of pulmonary toilet. You think you've made it. You think you're over the hump, and then that's when the pneumonia sets in, and you sort of start that battle over again. And this on the right is just sort of giving you the idea of how does this start and what causes it. Really, one of the big drivers that we've identified is interleukin-6 cytokine. However, like with everything in our body, if you specifically target IL-6 and you block it, the damage still happens. So while this does seem to be a major driver, we don't have that magic bullet to fix it yet, or to at least stop it. And then now that everything, they're tucked in, you've got them, they're breathing, all the systems are managed, temperature. Burned skin has a very high transudative evaporative water loss, or TEWL, compared to non-burned skin. You lose large amounts of water, and with that, you get the evaporative heat loss. So preventing hypothermia, crucial on these kiddos. Those operating rooms can get very, very hot, which is good for the patient, bad for us. You want to try and keep the temperature normal, but you can expect that hyperthermia as that inflammatory response kicks in, and this tends to persist for at least the first few days. And again, with any major offense to the patient, such as big surgeries. Well, and then to sort of round out the management, we say, okay, burns are uncomfortable, extremely painful. What do we do? How do we help keep these kids comfortable throughout their stay? So procedural pain and background pain. Background pain, once you get them in a good place, everything looks fair, they're doing okay, but then you do something to them. And unfortunately, like with everything else, we tend to give a lot, and then it's harder for us to take it away. Having protocols in place is helpful because it gives you sort of an algorithm or a ladder to follow. Continuous IV pain management is certainly our first line for these kids. We always try to steer clear from things like opioids, but in these big burns and these massive painful events, it is necessary. Fentanyl, fantastic drug on paper. Rapid clearance can give a lot of its, does work well. No major pro-epileptic metabolites like Dilaudid. You know, if you have renal failure, you got to be a little careful with the Dilaudid. Breakthrough pain therapy. So you've got your continuous boluses off the pump, and these can be a little bit aggressively used sometimes. So, you know, I always say if we're given a lot of boluses, we need to just increase our background management. And then once we start using less and less or no boluses, none of these PRNs, start backing it down, because this is a marathon. And the end goal is for them to slowly be off of these medications. So can be very difficult de-escalate. And then what are our adjuncts? Tylenol, we love it. Tylenol plus ibuprofen, ketorolac, you know, your NSAIDs tends to do well. Certainly, you know, does well in the studies. However, in these big traumas and big burns, the efficacy maybe not as pronounced. Certainly useful for temperature control. Gabapentin, there's some data. The data on this one is a little bit more plus than minus, I will say. We certainly use a fair amount of it, and it does tend to reduce some of that background buzzing, tingling, neuropathic pain. But does it make us or allow us to use less opioids? And that's where the data gets soft and says, doesn't seem to. That, or we're just, we buckle, we cave, and we give it anyways. And then, of course, methadone. Methadone has good data for these kids. It does tend to work well, and it is something you can use as a great oral background agent. And then for our procedures, Precedex, central alpha-2 agent, works pretty well in kids. Tends to work more so better in kids than adults. Ketamine, I absolutely love ketamine. You can give it quick on, quick off. You can do a lot with it, and as long as you co-treat with a little bit of benzodiazepine, usually they have a pretty pleasant experience. But of course, there's always that emergence phenomenon we hear about where they can have sort of a waking nightmare. We try to avoid that. And then, of course, our last line agents are midazolam, your Verseds, propofol, because of the hypotension, because of the liver changes. These patients are already prone to have steatosis of the liver, increased triglycerides, their LDLs go all out of whack. So try not to use it if we can help it. And then the collaboratives that we have with the American Burn Association and other burn centers, we're always learning and growing. So anything that's new, anything that some centers coming out with, we try and learn from each other. And that's all I've got. So thank you guys for listening, and I would be happy to answer any questions. And how do you? Yeah, of course.
Fantastic. Leave that slide up so people can claim their CE credit. And then, yeah, guys, feel free to put your questions in the chat. Take a look, and let's see here we go. Any questions in the audience? I will hand you guys a microphone.
Yeah.
I can yell.
Oh, you can yell. Okay. Dr. Strage can yell. Okay.
In Galveston, you guys had a lot of kids nasally intubated. You and I have talked about this.
Yes.
So the EMTs usually won't do that on their way into the hospital. So would you guys just change them into a nasal intubation?
Yeah.
And when would you do that? Since they all swell up, and again, I'm a naysayer on that one, but then convince me I should do more.
Yeah. Thank you, Dr. Strage, the burn director. My boss. So we, within the first 24 to 48 hours, we would do a tube exchange. Now, how is that possible? Because the majority of our kids came from Central and South America. So we typically got them 48, 72, 5-6 days after the injury, after they had already survived resuscitation, when they were stable from swelling. The first thing we would do, they would come in, we would get them tucked in. The anesthesiologist would go in with a flexible bronchoscope into the nares and look and evaluate. If the anesthesiologist felt that the airway was safe for a tube exchange, then on our first trip to the operating room, they would load a nasal tube, park it right above the endotracheal, remove, and then go straight in with the replacement tube. And we did that for almost all patients. However, there, one or two cases here and there where perhaps the tube had already been in for a couple of weeks and we saw a little bit of infolding of the arytenoids, something that would make us say, if this tube comes out, the glottis will try to collapse. Those we would keep intubated or we would perform tracheostomy. And we did try to extubate within 48 hours after every surgery if it was safe to do so. But no, good question, great question. There was some words exchanged at ABA this year between the Sacramento Shriners and the Galveston Shriners. One tracheostomy is king, one nasal intubation is king, and they both have good outcomes. So, it's hard to say my way is better when your way gets it done too.
Good question.
Yeah.
There's a question in the chat.
Of course.
Are all facial transplants more successful for bad facial burns?
Okay, so full facial transplants. Now that is something that is newer. I won't say new because it's been done in some centers for I think 2 decades now, a little over 2 decades. A full face transplant for a burn patient is only considered for patients that have complete loss of all of the skin, most of the musculature, and the cartilages, such as the nasal cartilage. They've lost their tarsal plates, which is the connective tissue for the eyelids. The morbidity on a face transplant is extremely high, unfortunately, and the issue comes from the amount of antigen-presenting cells or immune cells that are present within the skin, and particular within the face because of the high concentration of blood flow. So these could be performed, but I've not personally seen one or taken care of one. I have read some articles. It's certainly not something that we routinely do. And our modern adjuncts, such as our dermal substitutes, meaning biodegradable or bioresorbable compounds that can be placed on the skin and allow for ingrowth of the granulation tissue, certainly makes facial grafting easier, a little prettier, but not perfect. And then as far as the next question, yeah, of course. So the next question is, for those of us that practice rural austere emergency medicine, the medevac times of 6 to 48 hours, we're aware of the pullback in patient or in adults on aggressive fluid resuscitation. In kids, should we be starting at 1 milliliter per kilogram per percent TBSA and adding an FFP at 10 milliliters per kilogram, shooting for that 1 milliliter per kilogram of urine output? Or should we start with the 2 milliliters per kilogram and watch urine output, only bolus for polytrauma? So the recommendation as it stands right now is to start these kids between, depending on their age, between 2 and 3, or between 2 and 4 milliliters per kilogram per hour percent TBSA. The younger the kiddo, then you're looking at that 3 milliliters per kilogram. The 4 milliliters per kilogram, of course, is the classic Parkland formula, whereas the modified Brook is what we talk about when we say 2 milliliters per kilogram. I do think in the next maybe 5 years or so, maybe a little more, we will start using pre-hospital fresh frozen plasma for these large burns. As far as the amount administered, if you want to go back to the classic West Penn formula, they did it as a amount of 30 milliliters per kilogram over a few days. But I think the key thing is making sure that your resuscitation is adequate, that you avoid boluses, and that you get them somewhere quickly. And that's hard to do in many cases, but always remember the under resuscitation is somewhat less devastating than over. So, you know, if you're giving these kids that fluid and you're able to get away with that 2 milliliters per kilogram per percent, and of course, this is a guideline. So you watch that urine output. FFP certainly shows a lot of promise. And I think when we're looking at, I need something more, FFP does have some good data and does have some good lab data as well to say that it helps with that fluid creep and that capillary leak. But excellent question. Oh, what temperature should your home water heater be set at? Now that is
one of our prevention people must be.
this, yeah, spread the news, 120, 125 at the most. You know, it is, you don't realize how hot water can be until you go to a hotel and turn the shower on hot. Because those, I don't know if they think that you're just there to blister your skin off, but you know, these hot water heaters can get up to 180 degrees. That is insane. That is coffee fresh from the tap. And at those temperatures, it is near instantaneous full thickness burn. It is incredible how quickly the damage can occur. If you have small children, your water heater should not be above 120 to 125, and you certainly shouldn't leave them unattended in the tub, even though they're just playing, because when they get a hold of the temp, you know, handle and they pull it to hot, they can't escape. Same thing goes for microwave noodles, ramen noodles. I don't even want to talk about it, but it is, and then you know, there's that's a whole nother topic. But I will say, education, especially if you're in a primary care role, a pediatrics role, only the adults should be doing this, should be microwaving, should be testing, managing. Don't give it to your kids unattended. But unfortunately, there is a socioeconomic variable in that the most likely scalded, injured kids are the lowest income, the highest number of distractors, family, other family, geriatric family in the house, multiple brothers, sisters, low resources. So sometimes it's just, you can tell these people, well, just watch your kids better, do everything for them, but that's not possible and that's not realistic. But at least getting the information out there. Okay.
Fantastic. Thank you so much. Any other questions in the room? Oh,
yeah.
Dr. Sun.
My question is, do you think there's going to be more to the interleukin story in the future? Because in PICU, we've been seeing a lot of these hyperinflammatory illnesses, especially the NISC, and been really impressed by using like TOSI and anakinra, the IL inhibitors, and absolutely trust that information. So do you think it's been like people shut the door on that, or there's going to be more to it?
No, I don't think they've shut the door at all. And I think one of the avenues that we're looking at down in San Antonio is a real big push for this, because you know, you're thinking, what can I do in a potentially a combat setting to get someone stabilized or to get them to the point where we can use a less fluid to get them through to a definitive treatment. Is what if we extract some of those cytokines? What if we put them on CVVHDH? So hemodiafiltration. What if we use large amounts of solvent drag to pull out these mid-sized inflammatory cytokines? And what they found is that it does significantly reduce the amount of volume you have to give to your patients. It does not make them live more. So anytime you're in a situation, and that's just based on the data that they have, you know, 30 or so patients. But I think that something like this CVVHDH, which is a relatively easy way to get these inflammatory cytokines out of your system, or certain drugs that target and essentially inactivate these interleukins, will become useful in the future. But they also, it carries with it other side effects. And one of the big ones that we saw during COVID in particular on patients that were on Actemra, the IL-6 inhibitor, is you were at a higher risk for bowel perforation, spontaneous bowel perforation. So dialing it in, I don't want them to close the door on that, because I do think if we can clear and halt that immune response, we can reset and then make that ground up. But as of right now, in my world, in the burn world, people, they don't live more, but the ones that do live have fewer complications from volume resuscitation. Yes. Is water temperature a routine thing to mention at 6-month well child? I'm not a pediatrician, so I don't know. That's a great question. That's a great thought. I'm hopeful, but do we have any personal experience? 6-month well child visit, is water temperature mentioned, or is water temperature mentioned, you know, at any of your pediatric encounters? And it certainly should be. I'd have to look into that because the second you go home with a new kiddo, there should be a flyer that says, "Here's your safe sleep. Here's your safe bathing. Here's your safe everything. Here's a do not eat hot cheese dip over your child." Okay, seems like duh, no brainer, but people get hungry and babies they don't want to be put down. So, yes, ma'am, in the back.
And I do tend to mention it around the time like they're starting to be able to bathe babies, like they lose their umbilical cord. So that's something that we do bring up. I don't know how many people routinely bring it up.
Yeah.
Definitely.
Yeah, I'm not sure, but it certainly is, I think, useful. And the other side of it is it brings some awareness to, oh, I can adjust that, because I can promise you a bunch of people think the hot water heaters just come from the shop at a temperature, and that's just what you get. So, all right, well, thank you again, and thank you for letting me talk. Yeah.
Thank you all for joining us today. We have some great grand rounds coming up in June, so be sure to check those out as well. But thank you for those of you at home that joined us, and thank you everybody for joining us in person. Have a great rest of your day.
We have a lot of